2009, 23.7 million people with the disease. 2034, the forecasting and projection is 44.1 million. Now, if we look at the direct medical costs on the Medicare population, plan together to get them in front of the PCP, that it is most definitely going to, be beneficial for the member first and foremost.
But on a lot of those members, they are not established with the PCP that they're assigned to. These are members that have either transferred and never been to the PCP that they were transferred to, or they've enrolled and never seen a PCP. Some of them don't know how to use their insurance. There's just a lot of things out there, and I know that for my office, for my practice, that we use our roster and we track the new patients that are added to our panel, and that way we can make sure that by the end of the month we've reached out to them if they haven't contacted us. And it's already done for the correct.
We are adamant that we try to get that member back in front of their primary care doctor as soon as possible after they've been discharged from a facility. And the data tells a story. It truly does, and it's surprising, but I think it's due to his aggressive treatment of the disease.
It is, definitely.
All right, as I said, diabetes. If we could have an impact on diabetes alone, we will make such a difference. And the majority of
issues that he had was that he could not have a definitive clinical test that's going to say, okay, that patient's renal failure came from their diabetes. There's very few instances in which we can truly diagnostically connect the manifestation to the diabetes. So he was very hesitant. But in 250.70, diabetes with peripheral circulatory disorders, there is no manifestation clause. It doesn't say that. It just says a disorder. It doesn't matter. We always want to make sure that we document the complications or the manifestations. You've got to state a relationship. There's got to be some kind of causative relationship between the two to be able to code it as a manifestation or a complication. If our patient uses insulin, we want to make sure that we put that on the claim at least once a year. Okay, so yeah, this is right out of the CMS Medicare database.
On one of the systems, I think MOMS only allows you to submit 4 codes. Am I correct in that? Well, what if you can only submit 4 codes, and we know with 5010 the changes are coming. You're going to have to be able to, the clearinghouse is going to have to take 8, I believe. Am I correct in saying that?
You are correct, but the difference is that I want a system where I can put 8 diagnoses in there, but I cannot attach each of them. I cannot attach more than 4 to a service line. So in order to attach all 8 to a service line, I would have to have multiple service lines in which I could attach those to. Because just if I list the diagnoses, the 8 diagnoses, if I fill up all my boxes, you're not going to be able to capture those codes because you can only capture the codes that are attached to a service line.
And we've just now started to see, what she has been doing, this effort starting to incrementalize as far as that risk-adjusted factor. So can you imagine a football team that the offensive linemen, the wide receivers, the quarterbacks, they never practiced together. I mean, they were all on offense. You had your defensive guys, but they never practiced together. But come Saturday night or Sunday, you hear the roar of the crowd, and you're in the tunnel. You're about to go out onto that field, and you're about to play. But the guys that your team, you've never practiced with before. In essence, I feel like that's sometimes what we're doing, and I want to empower the people in the office. And I'm not saying that we're going to be able to set something up that Cameron and Dr. McCullough, when Dr. McCullough handed off those charts, he knew that somebody was going to be looking over his shoulder. And the Hawthorne effect, if you will, that we know somebody's watching, it changes behavior. And I don't want to say it was somewhat of a game.
Yeah, I think it was, because our offices, of course, I have an office up front, and then I also have an office in the back that's kind of across the hall from his. So when I'm back there dictating or auditing him, I can see him kind of sticking his head sideways through the door trying to see, okay, well, is she making changes? Did she open the chart? Did she audit it? And I will say that in the beginning, every single patient, every single one of them. Now, I can't hardly find anything to go back there and query him on. He's doing so good. So if you're sending a patient to Krista Spahn and you enter it into the RAE, you're going to, when you get your paper to fax over, it's not going to have their Spahn tax ID on it. It's going to have their payer-specific ID unless I can get that changed.
waiting outside their door. I mean, I don't want to hear that as an excuse that they can't, travel. We will take care of that. And we see up there common goals, quality, and we talked about it a moment ago as far as that value equals quality divided by cost. What we're trying to do, it's not easy, and it's not for the faint of heart. And I know that that there have been difficulties.
On a smaller area, I don't want to try to ask you to have a sip of water out of a fire hose. That doesn't do any of us any good. Osteomyelitis, in between the diabetic ulcer and the osteomyelitis, cellulitis. I said colitis last night, and she made fun of it. I didn't mean to say colitis. I meant to say cellulitis. So we got the ulcer, we get a cut, we're out playing golf, whatever the case is, we get a little slice on our foot, we get the diabetic ulcer, cellulitis, osteomyelitis, gangrene, and then guess what happens? Break toe, ankle, below the knee, above the knee.
So what goes into this model? What makes it up? It's definitely not a one-sided model like we are used to in so much of the reimbursement today. And so it looks for its perspective. This is something that they are trying to use to predict future costs. However, when we were doing HCC coding, it's different because these claims, the claims data that CMS gets is all that they have for them to get a picture of our patients and the members. And if we don't give them a full, clear picture of that member, then they don't know how to reimburse appropriately.
We've already mentioned as far as that standard of care, every 90 days, the hemoglobin A1C, fasting blood sugar, medication reconciliation. I don't want to over the foot checks and the eye exam, that's huge. The foot checks and the eye exam, it's huge, it's significant.
It's HEDIS also.
It's HEDIS as well. And the 72-hour follow-up post-discharge, that's one thing that I want to address that it's so key. We know medication reconciliation is the #1 reason for readmits within that 30-day time period post-discharge. We want to get them back in front of their primary care physician within 72 hours. Now I know if
the laminated one on the back where it has the diabetes, you will see under each of the 250 codes, there is a list of common complications or common manifestations that are associated with that code. So if you kind of can get into the practice of using that, it's going to make it a much easier task.
We don't know what the disease or illness is going to be 18 months from now, but I can tell you just from my time in healthcare, chances are it's going to be a little more expensive than it is today. It's like the gross domestic product. Since 2008, this nation has been in a bit of trouble as far as what has happened to real estate. Medical inflation, it's kicked right on about 6–7%. Everything else has just crashed, but medical inflation continues to roll. You got to have that innovation and technology, and we're going to work towards that. But it's just a huge difference between the two. And this is the 250. This is the one, and then these others are.
And on the 15, the 250.70 and the 250.40, both of those, I have found that those are very common. As far as the other 250 codes, and those are 15. So